Project Special Delivery is a medication-assisted substance abuse treatment program for people who are addicted to opioid drugs like heroin, OxyContin, morphine, methadone, and other prescription painkillers. In our program, like thousands across the country, we use medication that has been proven effective in helping people stop spiraling drug abuse and regain control of their lives. The medication we use at PSD right now is methadone, a synthetic opiate. There are about 1,300 methadone clinics in the U.S., 2 of which are in Alaska. They are all different. The treatment of opioid addiction with methadone has faced disapproval and discrimination almost since it started. One reason is that some people see it as replacing one addiction with another. While it is true that people are taking a medication, the fact is that this medicine does not act like the narcotics people were taking before. It does not make people high. It allows them to function normally, so they can do the hard work of changing their lives. They are able to focus on normal daily activities without impairment. Another reason that stigma has endured is that methadone itself does not magically fix everything in the addict's life. If they had no job skills before methadone, they won't magically be endowed with skills when they start taking the medication. Methadone programs are supposed to help people make the changes in themselves that will lead to self-sufficiency, good health, and a better quality of life. Some programs do this better than others, and some methadone patients are more ready than others to make real changes in their lives. We may be biased, but the staff and consumers at PSD think that our program is one of the best. Why, you ask? We are small, about 40 patients in 2012. Most clinics have hundreds, many have more than 1,000. As staff, we know our patients, who have, by the way, chosen to be called consumers. Another reason is that consumers are actively and genuinely involved in the direction of the program. PSD was developed by addicts for addicts. In 1999, a group of about 12 of them got together and asked IAA to start a methadone program. The director at the time, Bonnie McCorkadale, told them that IAA would sponsor the program if they, the addicts, did the work. They met almost every week for 14 months. They studied the regulations and standards, then wrote the policies and procedures. They completed the myriad of applications required to gain federal and state approval. They approached community leaders to ask for letters of support. PSD's first consumer, number 001, volunteered to talk to the chief of police. A 45-year heroin user, she joked that she had never talked face-to-face with a police chief when she wasn't in handcuffs. She got the letter of support and led the Consumer Advisory Council as they started the program and faced many challenges to keep it open. The Consumer Advisory Council remains an integral element of the program. Through the work of the Council, PSD manages to avoid the all-too-common us and them power struggle between consumers and staff. One of the biggest differences between PSD and many larger methadone programs is that PSD requires active participation in counseling and education to help consumers make fundamental changes in their lives. Methadone addresses the physical addiction, withdrawals, and cravings. Counseling addresses the rest of the issues that led to and sustained the addiction. These include cognitive and emotional challenges, family relationships, and lifestyle issues like health, work, education, and social support systems. The large private for-profit programs down south do not have the mandate that Alaskan nonprofit programs have to provide comprehensive services to patients, whether they want them or not. At PSD, consumers must participate. In a perfect world, no one would need methadone. In that perfect world, no one would have their life destroyed by addiction. This is not a perfect world. Methadone as treatment for addiction has saved thousands and thousands of lives. It has also gained an image, a stereotype, of heroin addicts getting their fix from a methadone clinic instead of their dealer. Not all clinics require as much participation in counseling and education as PSD does. We don't have long lines down the sidewalk with people waiting to get their doses. They are treated with dignity, not like they're criminals. We expect that they will learn not to act like criminals and most succeed. The program ensures that they have access to support that can help improve their lives. Recovery and medication-assisted treatment is an ongoing process. It may take many months or years. Methadone starts that recovery process, but the rest depends on how much the patient, the consumer, wants the recovery process to work. Staff help the consumers meet their goals and make the life changes necessary for recovery.